Do you leave every doctor's appointment with more prescriptions and referrals and also more questions? Oh, friend, you're in the right place. I'm Kayla, registered nurse and personal medical strategist, and here every week we're going to work together to cut through the noise, connect the dots, and finally get you the real plan you deserve. Let's dive in. Hey, welcome back to the podcast. So today I am so excited to dive into what I call my breadcrumb method. So, have you ever had an appointment and you had a hunch or a suspicion about what was wrong, but then when you tell the doctor directly, they dismiss you? Well, you're not alone in that scenario. And what if instead you could guide them to your conclusion and have them think it was your idea? That is the whole thought process behind the breadcrumb method. This is something I'm sure I'm not the first to do this, but this is a technique that I kind of unintentionally developed throughout my time as a bedside nurse because guess what? It is not just patients who sometimes have a hard time getting the doctor to hear what they're thinking. That can happen with other clinicians as well. This really kind of undermines some or highlights the importance of communication in the healthcare setting, going back to what I was talking about in the previous episode. So, this is just a slightly different take on it. Now, this happens for a variety of reasons. First of all, doctors typically are under considerable pressure, not just from, having to figure things out medically, and that is a lot of pressure, but also the time constraints. And for the most part, most providers are working with really more patients than they would prefer to. And so, kind of jumping to the answer and figuring out the plan, there's not as much time and space to breathe. And that's part of what's fueling their concept of wanting to just stay in control, steer the ship, and keep things moving, right? Another part of it is they are truly in a leadership role on the healthcare team, and they're trained that way. But like I said in the previous episode, they are trained into that leading the team position, but they don't get leadership training or effective communication skill training, at least probably not to the extent that I think would be beneficial. If I was queen and ruled the world, those things would be part of med school. Um, However, this combined with the fact that since the advent of the internet and patients being able to search their own symptoms, the problem is when you're searching online, and you don't have a clinical background, sometimes things can seem like they fit, but they really don't. I think everybody's kind of heard that phrase, especially when WebMD came out, like don't Google your symptoms or don't look it up on WebMD because you'll be convinced you have cancer. And that, for some people, it's just like a haha funny story. But speaking from a clinician's perspective at the bedside, that kind of situation actually occurs a lot. There's been many, many times where I've seen patients, especially in my experience, this has been like in the ER, and people will come in convinced that they have, XYZ condition, and actually like their tests come back that it's definitely not that, or there's just other context to the situation that they're unaware of. And oftentimes, I personally have had a lot of experiences where patients are not receptive to that information that, hey, this isn't adding up. I don't think it's that. And I know I'm not the only one who's had that experience. And, they say it only takes one person to ruin the party. And so, unfortunately, a lot of your providers are also carrying along that baggage of having these previous experiences where patients come in convinced of what they have and honestly at times argumentative, and it's just left a really negative experience. And so Sometimes, if you've had a negative experience with one person in a situation, all similar situations moving forward, kind of your brain kind of categorizes that as, oh, I've been here before. So that's part of not to justify it, but just to help explain the context around why this happens. Also, in full candidness, I'll say it that oftentimes doctors have an ego problem. Again, this is not a blanket statement. This isn't all doctors, thank goodness. But I'm sure we've all met one who their ego was so big, you wonder how their head managed to fit through the doorway. So especially in situations where a doctor is leaning more that direction, this breadcrumb technique tends to be very handy. So, without further ado, what do I mean by the breadcrumb technique? So it's kind of like that, the storybook of Hansel and Gretel, and they leave a trail of breadcrumbs that ends up getting them to the witch's house, I think. You know what? I didn't even look up the fable. It's been so long. But I'm pretty sure that's the concept. Or also think of the movie Inception, if you've ever watched that, and how but the whole concept is to lead somebody to the conclusion, but have them feel like it was their idea. So, how do we do that? I have 4 steps that I'm going to leave you with how to execute this, and I'll tell an example along the way. So, let's say that in this example, we're going to focus on POTS. POTS is an autonomic condition called postural orthostatic tachycardia syndrome. And it's a nervous system disorder that causes cardiovascular symptoms. For whatever reason, I mean, I remember learning about it in nursing school and I've been aware of it since then, but it tends to people with POTS tend to have a hard time getting a diagnosis. That is one of the conditions that it actually often takes many years to get a diagnosis. So for any of my you think it's POTS people out there, this one may be particularly helpful for you, but either way, the framework can be applied in any situation. So, step 1, you always start with curiosity, not conclusions. I cannot emphasize that enough. This entire time, we're going to be asking questions, not making statements. That's going to appeal to your clinician's natural curiosity and kind of put them in a position where they feel like the investigator, which is truly what they want to be doing for you when you are trying to pursue a diagnosis, as opposed to you present something and the natural response then is to you're kind of on the defense because then the clinician either has to explain why or why not. That's not the thing. So, in all times in healthcare, in life in general, we want to make sure that we are keeping our conversation very, kind of cohesive and staying on the same team. And we really want to avoid creating an us versus them dynamic, which is often where I see communication in healthcare situations, particularly between patient and staff, break down. So, step 1, start with curiosity, not conclusions. So, in this example with POTS, you could say something along the lines of, can we walk through what might cause XYZ symptom? Say dizziness when standing, especially when it only happens after I've been standing for a while. So this is a time where you're going to highlight a symptom, a main issue that you're dealing with, and then provide some context around it that's going to help to specifically narrow that pool of possibilities. Um, again, this is why when I was talking in the previous episode, I said, make sure you have a priority for the appointment. And I really encourage you to pick just one. That's so that we can get deep and specific on that one and actually make a lot more progress than if we're trying to cover a lot of ground in a lot of areas and getting spread thin. So, step two is narrow the thinking patterns. In this example with the POTS, we could say something like, I've noticed that my heart rate jumps 40 beats a minute when I stand, but my blood pressure stays about the same. What could cause that? You see how this is very specific. This is where documenting your symptoms in a log is going to become really, really helpful so that we can point to that specific information. And now we have taken dizziness, which is rather non-specific and applies across a lot of different conditions. And we've now named the pattern that is very specific to a much smaller group of possible conditions. Step three, name the category without naming the test. So, for example, would this fall under autonomic dysfunction or something similar? So, this gently introduces a clinical frame. So, you're kind of getting their thinking a little bit more narrowed in, but you're not sounding like you like Google, like a Google doctor, which of course is the connotation we want to stay away from. Step four is where we finally point to the test, but again, we're keeping this framed as a question. So, example, would a tilt table test or something similar help clarify that? Or is there another way we should evaluate this? This this whole tone, the whole way through, invites collaboration, appeals to their curiosity, and really points to them as still being the leader in this while still getting them where you need them to go. Um, Make sure that you are using logic as much as possible. Again, going back to your log of symptoms and use it to support your request. So, an example here that still relates to this specific clinical situation, you mentioned that my symptoms seem positional. So, would imaging or autonomic testing be the next logical step? And if despite all of this, you still can't get them on board or moving in the direction that you think things need to go, couple of things. Number one, I always encourage my clients, and this is a great time to remind you that you are the expert in your own body. You know when something is wrong. And unless you have a medical degree and a clinical background, you don't have all of the clinical nuance that goes around medicine to you don't always definitely know what it is or isn't. So always, I encourage you always to remain open to conversation because they may have really good reasons that you weren't aware of for why what you thought it was doesn't actually fit the clinical picture. So I just please encourage you that if they have, a retort or something to say back, listen to it and maybe it makes sense. I've been surprised more than once the outcome of this. I don't know everything either, but it still just goes to show that having the conversation in an open conversation and keeping that teamwork dialogue still got us where we needed to be. It just wasn't exactly the destination that I thought it was going to be, which is, hey, that's fine. This isn't an ego game, and it's not about me being right or wrong. It's about getting the answer, right? So I just wanted to keep you kind of throw that out there that, sometimes the win isn't what you think it's going to be. And it's so interesting. Like the longer that I work in healthcare, the more and more I start to see that it really there's a reason that it's called practicing medicine. There's just so much nuance. It's hard to explain, but there's just so much nuance around anatomy and physiology and when things go wrong, pathophysiology and just how the human body works and normal variance from person to person. And all of that kind of interplays to why so many things like just don't have a clear answer. I mean, even just, take a step back and look at all of the people or like people around you. People come in a wide variety of normal, and it doesn't stop on the surface. Side tangent. But just to wrap this up, so the 4 steps: start with curiosity, not conclusions. Narrow their thinking with patterns. Name the category without naming the test. And finally, point to the test, but as a question. It works because you're letting the doctor maintain authority while guiding the conversation toward your goal. You're not being manipulative, but you are being strategic in a system where direct requests often get stonewalled. It's like I've said in the beginning of the podcast, and literally like almost every day that I do this work, it's wild that this is what's required. Like, this is healthcare today. You got to get this strategic about it. And I wish it wasn't that way. But at the same time, there's nothing I can do about the way that it is other than help you figure out how to navigate around that. So I hope that this was helpful. It's kind of a part 2 to the how to get your doctor to listen to you. Honestly, there's so many pieces that fit into that bucket that I know we'll just keep talking about on the podcast. But thanks for coming back with me this week. And next week, we are going to talk about what to do when you get different answers from doctors and how to make sense of that. Um, Spoiler alert, it has more to do with more of that nuance that I was just mentioning a few minutes ago. So come back next week, Monday at 5 a.m. for that one. I'll see you there. Stay healthy, friends. Don't you go to another appointment unprepared. Head on over to herdforlife.com/guide and get my free doctor's appointment prep guide so you can start getting the answers you need and get off the medical merry-go-round. I'll see you next week.